Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is Seamless MD's CEO, Dr. Joshua Liu. Today we're joined by two amazing guests. We have Summer Blackerby, the Chief Nursing Information Officer at CoxHealth, and Gina Ellerbee, Administrative Director of Nursing Practice and Professional Development at CoxHealth. Summer and Gina, welcome to the show.
Thank you for having us.
Well, thanks so much for joining today. You've both been so instrumental in leading one of the most important digital transformations in healthcare, virtual nursing. And I'm so excited to talk to you both about that topic today. But before we get into the weeds of it, I was curious to first understand what motivated you to get into nursing to begin with. And maybe for Gina, what pushed you towards administration? And then for Summer, what pushed you more towards informatics and technology?
Yeah, so this is Gina. I will start. This is a question I get quite a bit. So I don't know that there was any one deciding factor for me to be a nurse. I just always loved the hospital. I loved the hospital setting. I was actually a candy striper here in this hospital when it opened when I was like 15.
Yeah.
So it was something I just always wanted to do. And I was a bedside nurse in critical care for many, many years and loved taking care of my patients. I loved what I could do for the patients and for our families. So when I went back to school, I became a clinical nurse specialist with an emphasis in critical care. And as I was going through my programs, I really learned that I loved teaching and I loved supporting our nursing staff and really being a nurse's nurse. And that is what really led me down the path of leadership, is really fully understanding that as a nurse could take care of my two patients, and those were two patients that I impacted, but being a leader, I could encourage and support and teach other nurses that are taking care of hundreds of patients. And so it really was just a matter of trying to expand my potential scope of influence.
Yeah, this is Summer, and I can build off of that a little bit. Similar to Gina, I always somewhat knew that I wanted to be in healthcare. I think my first aspiration was I wanted to be a pediatrician. Actually, that's a path I started down in college. And then about a year in, I decided that I was going to change over to nursing. I had several family members who were in healthcare, so it was just something that I always had my eye on, I think is why I wound up there. As a nurse, I worked in med-surg and ultimately ended up in a pediatric clinic. So I guess I checked the pediatric box there for a little while. I think the transition into IT is I was a part of several of the first EHRs as they were being implemented, especially in the ambulatory space. And I just kind of gravitated to it naturally, I guess. I was kind of that super user, really found it fascinating and really kind of enjoyed the process of providing feedback into trying to make the overall workflow better. And so when they had an educator position open up, I applied for that. And shortly after that, the hospital that I was with, we acquired that hospital into our current system now, but they signed a contract to implement a system broadly that included inpatient documentation, orders, et cetera. So I really got to cut my teeth there. I look back and that was a really unique experience. And so I learned a lot, and fast forward 15 plus years, still in that space and still loving it, love the challenge that it brings every day. And also the ability to impact the clinician's workflow at a greater scale, really advocating for technology that makes sense to them. I find that really rewarding instead of just layering things onto them that may not be as intuitive within their workflow. So I think that's what keeps me focused here.
I think the common theme that I've been hearing is you both are really big on how do we impact, more patients by empowering providers better, whether it's through, education, whether it's through technology. That's awesome. So Al and I first saw you speak at HIMSS this year, where you were doing this amazing presentation on virtual nursing. And one of the really novel things about what you did was you did your initial pilot in virtual nursing, not in 6 months, but in 9 days. And it was like a proof of concept. I think you called it your Frankenstein project in the past to figure out if virtual nursing was viable. And if we remember right, you were really scrappy. You guys kind of just grabbed a few things off the shelf to make it work. Can you tell us about the origins of that and what the whole scrappy 9-day pilot was all about?
Yeah, I definitely can. This was something we had in our parking lot. So recovering from COVID, we had this idea during COVID of like, how great would it be if we could do this? And it just wasn't the right time or the right place. And so we kind of put that aside and thought this will be great for later. And it kept coming up. It kept bubbling up. Summer heard about it in a conference that she was at. I was reading articles about virtual care and really looking at the med search space. So, virtual care in the ICU setting has been done for a long time, and we were kind of behind the times in that, but really looking at the med search space, it was, again, the right time, the right place. We had a new CEO, we had a new strategic plan. We were wanting to try to get funding, and so our systems CNO basically said, if you're going to do this and try to get enough data to prove and request funding for this for next year, you need to get this started right now. And so we were scrappy, and we giggle and laugh all the time that we were called Frankenstein because it did feel like that. It really did feel like that.
I want to give Alan and Josh credit for that because I think maybe you guys helped us label that pilot as a Frankenstein pilot. Not sure coming out of HIMSS, but yeah, we were very scrappy. I left the meeting 30 minutes early and I came back and Gina's like, we have 9 days. So I think we will both tell you that that's probably one of the biggest benefits in our whole project is because we had to be so agile. We didn't have time to overthink it, over-architect it. If we did, we would probably still be trying to get everything perfect even today, like before we start, because in healthcare, we just tend to go slow. So I think that having a really short runway, luckily, we had been doing quite a bit of research and we had an idea of what we would need. And then we had an amazing team that really got behind us and helped us find the devices and stuff because we just used what we had on hand.
Yeah, we were pulling webcams out of drawers and I think we purchased one. We spent a total of $250 on our pilot, found space for our people, and just really worked through the process in real time, literally flying the plane as we were building it.
Today's episode is brought to you by DeepScribe, AI clinical documentation that physicians and health systems love, documenting specialty and complex care with ease and precision. Josh, have you heard all the buzz around ambient AI and virtual scribes?
Definitely. Clinicians are spending hours a day on documentation, so improving their day-to-day and reducing burnout is huge right now. You and I have seen quite a few product demos for ambient this year, but I have to say, DeepScribe was one of the most impressive.
Well, Josh, you trained as a clinician. What stood out to you most about DeepScribe?
Well, using AI to transcribe and summarize the clinician-patient conversation is honestly table stakes right now. But a big challenge for CMIOs and CIOs is driving actual clinician adoption. So what really impressed me about DeepScribe is how well it can be customized to different specialties and workflows with dozens of templates as starting points. That would be critical to me as a clinician because I just don't have time to build templates from scratch.
So true. For me, I was particularly impressed by the auditable notes. You can highlight any part of a note, and then DeepScribe shows you exactly where in the transcript the note was generated from. So you can find that evidence right away. That builds trust.
Oh, exactly. Being able to confirm that something wasn't hallucinated is so important for clinician trust and safety.
Yeah, that same attention to detail that led to really high clinician adoption is also resulting with clinicians saving up to 75% of documentation time.
Wow, that's incredible. But how is DeepScribe's accuracy with specialty care or complex cases?
That's the best part. DeepScribe's proprietary LLM, Heal AI, is trained on over 3 million patient conversations. It's then further tuned by specialty and subspecialty cases, making it way more accurate than GPT-4-based solutions. Pair that accuracy with DeepScribe's customization studio to personalize the experience for different clinician preferences and workflows, and it becomes incredibly flexible.
Alan, speaking of flexibility, I could use some yoga myself. Flexibility is key when it comes to working with health systems with so many moving parts. DeepScribe sounds fantastic. Where can health systems learn more?
About your yoga? I don't think they want to. But about DeepScribe, check out deepscribe.ai. That's deepscribe.ai to learn more.
That's amazing. So what was the process for going from that scrappy pilot to the scale that you have today? Like, what were the proof points along the way? Like, when was it the right time to actually maybe invest in a more, comprehensive infrastructure for this? How did you figure that all out?
Yeah, it was pretty early on in our pilot. We were seeing and hearing and witnessing in real time great saves. Our staff were satisfied. They were leaving work on time. They were leaving work feeling really satisfied in the care that they had provided. Our trial, our pilot, we started with 2 med-surg units, actually half of a unit, and we could only staff it 3 days a week. And so we were really reliant on looking at process measures and a lot of anecdotal storytelling, because there wasn't any hard, you can't say 3 days a week and extrapolate that to the outcome measures that we have to look at that are for care that's being provided 7 days a week. And so we had to pull out the things of efficiency. How quickly could we get admissions and discharges done on the days that we were staffed? What was our throughput like? What was the satisfaction of our staff, the satisfaction of our nurses with our pilot? And then we really just took the program, we really just took people through it. We brought our senior leaders to the floors to talk to the staff. We brought them through what was our little command center. At that time, it was like a little closet that we had 2 computers in. We let them watch and observe and see what our staff were doing with really bare minimum type things. We really relied a lot on just storytelling and showing them what we could do in a really short amount of time.
Amazing. Do you mind sharing a bit about like what KPIs or metrics you're now using today to measure success with the program?
Yeah, absolutely. So there's a lot of information to look at. So we're looking at a lot of our outcomes, mortality, length of stay, our sepsis mortality, and really looking at big overarching things like throughput, our discharges by noon, how many patients are we getting out of the ED and into a bed and not making them wait for those, looking at patient satisfaction scores, specifically around communication, medication, discharge readiness, discharge teaching. So how well are we communicating to our patients with their discharges, and hopefully turning that into reduction in our readmissions. We are seeing significant reduction in our hospital-acquired conditions. Infection rates are way down. We're looking at, I'm telling you, we're looking at everything, but also looking at our staff turnover rates and retention and their satisfaction of how well do they feel supported by the virtual care program. And we really started out as virtual nursing. Now you'll hear us refer to it as virtual care because it is multidisciplinary. We're looking at ICU avoidances, adverse event avoidances, all kinds of process and outcomes, big outcome measures.
I'm curious, question for both of you, but just to give a bit more context and a bit of a visual, what is the current operational workflow for the program? And the main reason I ask, I know a lot of programs start out, and I think yours even started out as more of a task-based responsibility kind of model. And I'm curious how that's evolved over time to where you are today, and what does it look like today?
Yeah, it definitely has evolved. And we started out focusing just on the few things that we thought we could do. So we were very task focused. And now we're very much, our staff is seen as just an extension of the care team. And so it really just depends on what is needed on the unit in that moment. If it is a heavy discharge day, then that is where their focus is. And it really just depends on what they need. So our care team is now multidisciplinary, that we have respiratory therapists, we have pharmacists, we have ICU virtual nurses, as well as med-surg virtual nurses. We have an early intervention team at our main hospital, and that is our boots on the ground ICU team that can actually be deployed for a patient who's having signs of deterioration earlier. We started that trial right after we started our virtual nurse trial, and they just slipped right in because they work together. They have such synergy that a virtual care nurse can say, hey, I'm cameraing in on this person and I'm concerned, and they'll be able to deploy that early intervention team. Initially, we called them a rapid response team, and we quickly changed the name because we found we could intervene before it even became a rapid response. So they are following up on patients that have early warning scores, and we're working together between virtual care and the bedside team to make sure that the patient's getting everything that they potentially need. So we will camera in on emergencies. We're doing admissions and discharges as well, but we're also doing quality of care, best practice review, making sure that nothing is getting missed. We are doing a lot of education, a lot of discharge teaching, a lot of medication teaching, trying to get patients ready for that transition to their home setting and what comes after that, making sure their appointments are set up. Our virtual care team can really help navigate complex discharges, making sure that patients are ready sooner to be able to go home and that they're more prepared when they do get home.
Can I ask you how you feel like that's changed, I guess, staffing requirements? So is it that you have the same number of staff essentially, but it's like you have different roles now or just different ways that folks are working together? Or have you actually been able to, I guess, have less staff deliver more care because this is just a much more efficient way of having the team operate?
Yeah, that's a good question. That was a question that came up really pretty early on, is if we have this resource, are we going to increase our ratios at the bedside? And we were very, very clear that that was not the goal or the intent. The care that's being provided in hospitals today is so much more complex than when I became a nurse 30 years ago. The things that a bedside nurse has to do, know, remember, coordinate is intense. It's way more. And so our goal was really just to take some of that off to allow them to have more time at the bedside, more time with their patients, more time connecting with the why they wanted to become a nurse and caring for the individuals. So it's really not a replacement for, it's just that we need this additional resource to actually get everything done that is expected to provide excellent patient care.
Mm-hmm. And Sarah, can I ask you a bit more about the technology? So I know when you did the initial Scrappy pilot, you were just, pulling webcams off, different shelves and all that. It's obviously a much more comprehensive program today. So are there a few key technologies that have been most important in how you operate the program today?
Yes, we really started exactly using what we had in place. We had a couple of rooms on the one unit that had cameras in place due to COVID. And then the other place that we started, they were using mobile parts. And we knew going in, like, we had a pretty good inkling that the in-room camera was going to allow our team to provide a lot more care than the nurse taking a cart, because by the time they got there, they could have already taken care of the task in many of those instances. So after we got into our pilot, we kind of passed that 90 days and we were gaining a lot of recognition and support from our leadership team. We knew that we had to go to market and really select a partner who was going to help us continue to grow this. Gina alluded to the fact that we didn't have an EICU model in place already. We were definitely late to that game. We'd evaluated it in the past, and we actually did have an EICU in one of our community hospitals, but it wasn't at scale across our enterprise. And so we really evaluated kind of one of the leading partners in the market. And what really led us to choosing them is they didn't have a big offering yet in the e-acute virtual nursing space, but they were willing to develop and solve the challenge and really help bring our vision to life. So we did have to select a platform. So we went with Philips software, and we've added in some of additional technology there. And I think that that's one of the questions we get a lot is, one, how did you get the investment? And then how did you choose a partner? And I really think it comes back to that human-centered design piece that we focused on in the beginning. Is we kind of gave the nurses the technology and then we stepped back and we just kind of let them problem solve. And daily they would come and say, I think we could probably, address this workflow here. And so we gave them the freedom to be innovative and really kind of problem solve. Some things worked really well. Some things did not work as well with the technology that we initially started with. But once we transitioned to the platform that we have now, a lot of it has been nurse driven. So, in a lot of projects, you kind of take the technology and you just give it to them. Here, we've really let them design the workflows. And so there's a lot of buy-in and a lot of benefit from them expanding the program just kind of organically as they started working in that space.
This is like a very different experience for a patient and family potentially. And I'm curious, if you're having a new patient family come in who's not familiar, how do you explain virtual nursing and the overall program to them? Like, what language or phrasing do you find most helpful to explain it to patients and families?
That's part of when they enter the room. Our team explains to them what's going to happen, what the additional technology is that they see there. And then our virtual nurses round on all of our patients and introduce themselves, and they explain, I'm here, I'm part of the team. Our families have been really receptive. They often try to scoot over and make sure they're also included when the nurses are cameraing in, because they want to engage, but they really build strong relationships with those virtual nurses. They're not shy about pushing that button. Our virtual nurses can fill a lot of information gaps because they often round with our providers and other things like that. So I think it's been really well received. Gina, what would you add to that?
Yeah, I second that. I definitely hear them talking and see them saying, I have 2 nurses, I have a second set of eyes. I think it really enhances the feeling of safety that our patients have, and they just really feel like somebody's looking over them, looking out for them. We have processes in place where if we have a patient who potentially is having signs of deterioration, we will add them and have an additional ICU nurse camera in and take a look at them and be on this EICU watch list for 24 hours. And I witnessed a family member that just said, I can't believe you know what's going on, you know the story, and the nurse knew exactly what they were looking for, what they were monitoring for, and made that family member feel better about, as we were watching out for them, we're making sure that they're safe. So we have had no issues really of people saying, oh, I don't want that. Most of them say, can I take them home with me? I really want this nurse to come home.
So that's a great segue maybe. Like, there's a lot of, growth of hospital at home and other programs right now. And so you have this really great model that works on the inpatient side. How does that connect to how you think about potentially supporting more care at home with virtual care?
I'll dive in a little bit, and then Summer can talk a lot more about it. But because I'm really focused on the inpatient side, I'm really looking at how can we leverage this to include some of those services that our patients are going to receive when they get home or on the outpatient side, for them to have those relationships and meet up and have that whoever that care team is, camera in, get to know that patient before they get home, see what that patient, what their condition is, what their potential anxiety is about, and try to make those connections and smooth out those transitions of care. And so we are looking right now, and we've had to prioritize, honestly, all of the ancillary departments that want to use this technology because everyone wants a piece of it. So we really just had to look and say, okay, who goes next? What makes sense? What's the highest patient impact? What improves a certain department's efficiency? What kind of resources could we provide that we aren't right now able to provide for our patients? And so we are looking at how can we potentially expand what we're doing. And Summer, I'll let you talk more about that from the IT side of all of the expansion that we're already doing for virtual care.
Yeah, we have virtual care that's already happening in the ambulatory space, but to build where Gina kind of left off, it's really how can we support the patient better across the continuum. I mean, in a perfect world, how great would it be if they could already meet their home health nurse who's going to see him tomorrow, right? Make sure that there's things in place that we need to know about, or, just making those transitions smooth to where they really feel like their care team knows them and can address needs that they have. I think that's one component. But even when we look outside of our 4 walls, situated where we are in our region, we potentially have the opportunity to support some of our neighboring facilities in ways that we have not been able to. We receive a lot of transfers in, and so having the ability to connect with those care teams and evaluate patients differently before they ever come to our facility could be an opportunity. It could also facilitate us getting that patient back to their home community. If they do need to come to our facility, maybe they get very targeted, specific treatments that aren't provided there. But, with some oversight and using telemedicine, we can provide specialty care, whether it be a physician or, a different care team. So I think we're certainly evaluating those options. I think our first focus right now is just continuing to get our program stable. Getting it staffed to that full 7 days a week is obviously very important before we can ever go outside of our 4 walls. But really, at least from what I've seen, there's not really a bad idea of how we can use telehealth. So when we selected a platform, we wanted one that was going to help us grow. So we didn't have like 5 vendors. We don't need 5 different cameras, 5 different things that are happening over here. So, I mean, to some degree, the potential is really great to do a lot of different things, some that we're probably not even thinking about today. But I'm really excited to see where it does take us and ultimately how that helps our patients, regardless of what care setting they're in. We live in a very rural area, and some of our patients, just to get to a physician, they're traveling. Sometimes an hour is not unheard of, but an hour and a half or more. So depending on the service that they're needing, could you save them that travel time and effectively deliver care via telehealth? In many instances, probably, which helps capacity in lots of other ways. And so we've got a lot of ideas. It's just kind of continuing to stabilize where we're at. And then, like Gina said, prioritizing the next area that we really go to.
Today's episode is brought to you by Seamless MD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what Seamless MD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. Seamless MD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on Seamless MD. Go to www.seamless.md. That's www.seamless.md to learn more. One follow-up that I had a little earlier, Summer, you alluded to the idea that when you were setting up the pilot, you were meeting with your nurses daily, collecting feedback and providing them really the space to innovate on their own and come up with ideas, which I think is really a fantastic idea. I'm curious how that's shifted over time. I don't believe you're still in there daily collecting feedback, but I'm curious, how are you addressing concerns and suggestions from the team today? Like, what's the cadence look like now that the pilot is scaled?
Yeah, we did meet every day at like 3:00 for the longest time, and we would give them the freedom to try that next workflow. I think now it's really grown into a whole department, and I think Gina can kind of address the structure. We have a nurse manager, and so it's really operationally like many of our other floors, but it's just a technology is the mechanism by which those teams are providing care.
Yeah, I definitely still go up there every day, but it's for a different purpose, because now it is like the best place to go to get inspired, because every day you will witness great collaboration. You'll witness a great save. We call it, we have a big space. It's 5,000 square foot command center. It's amazing and beautiful, but they call it the newsroom because everyone's kind of moving around, collaborating, asking questions, hey, come take a look at this patient. I'm worried about this, or have you thought about this? And so now I go and I round up there for completely different reasons. And it really is just to see the great work that they're doing. And it's a place to go that really makes you feel good about the work that we've done and the work that we've put in. We do have processes. We have advisory council. We are nowhere near perfect. And so we have lots of things in place that, hey, that we could do this better, or, Right now we're working on ICU transfer, medication reconciliation. And so we're working with our providers and pharmacists and all of those teams working together. But it is just very much an open dialogue. They know that we love change. They know that we're not married to any of this and that we may have come up with something a year ago that doesn't work anymore. And so we're just always willing to, let's try something new. Let's do something different. So it's very much just us listening to them, seeing what it is that they need, and trying to help them overcome any barriers that do happen to come up.
It's really that paradigm shift. I would almost say it's really allowed us to rethink at a very large scale how we deliver care, even from who's getting the alert. Like, do you really have to send that to the bedside team if you have a virtual nurse who's got all of the tools right there and can instantly reach that patient? They help triage and help prioritize requests so that the bedside care team is less interrupted. So like Gina said, a lot of the ideas are they feel very free to now say, hey, I think that we could do this workflow a little bit different, or I think we could take this off the bedside team. And so they continue to come up with great ideas, but at a very high level, it is really allowing us to rethink alert strategy, documentation fatigue, like what else could we possibly pull off? Where does it make sense? They've provided great feedback about how to optimize our charting, even like this is a duplicate over here. So they've allowed us to even fundamentally clean up some of the things that likely were just living in our EHR, but in any given day, that bedside nurse did not have the time to, log the ticket, request the help from IT. They just kind of lived with it, click, 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 get through it. So it's really opened our eyes to a lot of different opportunities for us to be more efficient.
Can I ask you, when you first started this, I can only imagine that a lot of folks, as with any new innovation, aren't excited about change. So I'm kind of curious, like, what were the biggest objections you were getting at the beginning? And then how did you overcome those objections?
Yeah, I think definitely everyone assumed that we were going to increase the patient ratios at the bedside. And that was the first thing right out of the gate that we had to say that is not happening. That's not our intention. We don't want to do that. And we did have, I remember day one, somebody got voluntold to come help with this project, and they weren't particularly pleased about it and said, I'm type A. I don't want anybody messing with my patient. I want to do everything, stay out of my stuff. And that nurse actually became one of our biggest cheerleaders because she could see the impact that it made on her day. She could see how when she left work, and all of the things were documented that could be documented, and all that was taken away of how great that felt. And then she knew she could duplicate that feeling for her coworkers. When she was the virtual nurse, she could do all of those things that's going to make her coworkers have a better day. And so the best thing I can say as far as naysayers is they just have to come up and see it. They just have to come spend a day. Yesterday when I was there, so we're getting students through, we're getting med students through, we're getting our new nurse residents. They all come and spend time because they need to know that this is a resource for them. And as I was talking with one of our new grads that was just there shadowing to see what they were doing, she was just in awe and couldn't believe, like, this is a resource that a new staff member has available to them, that they can just hit a button and ask a question. And so we really try to focus our team being very collaborative, communicative, finding something that helps the bedside nurse during their day. And they are much more likely that they will listen to you when you have other questions or concerns if you've done something that makes their day better. So we really do try to focus a little bit on the what's in it for me category of that. That has helped with buy-in significantly. I think also our staffing model is that we have staff that work on the floor as a bedside nurse, and then one day a week they will come and be a virtual nurse. We do have some full-time virtual only, that's all they're doing positions, but we do also have those hybrid positions. And so that helps. Not only does it give that nurse something different to do, a different way to think, new skills to learn, gives them a break, but it allows them to have those relationships with those people that they're working with at the bedside yesterday. Now I'm your virtual nurse. I'm still working beside you. And so the trust is already there. So that, I think, also helped us overcome a lot of those barriers, is that synergy was already there because they already saw each other as team members. For new people coming on, we travel to the other campuses to try to put faces with names and get to see their workflow in real life before we try to be their virtual nurse, so that we're trying to develop those relationships ahead of time.
I love the example of how, you turned a skeptic into a champion, because everyone else around them is like, oh, wow, that person is normally, the major skeptic in the room. If they're believing in this initiative, that means things working here. I love that. I apologize if you mentioned this earlier in the conversation. I might just be forgetting, but I'm wondering, in terms of the impact of this program on, clinician well-being, retention, burnout. Curious if you've got any feedback or any data on how this has impacted how staff are feeling about work.
Yeah, absolutely. We do quarterly surveys so that we can just take a temperature, kind of see how we're doing and get their feedback about what is the most helpful things that we're doing, and also asking the bedside staff if they have other ideas of things that we could be doing. So we monitor that to kind of make sure that we're still making those connections. Also, when you look at our turnover from before we started the pilot to now, we're about 50% improvement in our turnover. So we're below the national average. We're definitely way below where we were before when we started this. And so that alone really has helped, because that is allowing more staff to be at the bedside to care for the patients, because ultimately they're having a better work experience. Their satisfaction is higher because they have additional resources.
Well, that's excellent.
That's amazing. It's like that, the holy grail of how do we get better, safer patient care, better throughput, and yet somehow magically clinicians also feel better too. That's really amazing. Congratulations.
Yeah, very rarely do you have something that actually does both, that impacts patient care, quality, safety, and also improves the work life of your employees. And so I think that's what's been so great about this, is that we're doing both. And usually one is at the expense of the other.
Yeah. Awesome. So just being mindful of both your time, we're going to flip over to the Fast 5 lightning round. This is just kind of 5 rapid fire questions for you both.
Okay.
And we'll go one at a time. But the first question we have is, what is your favorite book or book you've gifted the most? And whoever wants to answer it first can jump in.
Can I jump in, Summer? And then I'll
go right ahead. These questions stress me out. So you go right ahead and go first.
Oh, no.
Okay. I think the book, I give this book to anyone who has a baby, and it's called Swimmy, and it's from the early 60s, and it's a picture book, but it's about a small fish, and he's different than all the rest of the fish in the school. And this is kind of sad, but he's the only survivor of this really kind of brutal attack. And so he meets up with a new group of fish, and he teaches the other fish how they all could swim together to look like one big fish, so that they can all be safer and happier together. And I love that book. I love the message behind the book. I kind of live that, in that we're all better together. And one person is one person, but when we're all swimming in the same direction, like the impact that we can make. Kind of cheesy, but it's totally my favorite book.
That's awesome.
I don't read a lot. I have a very small child, so my free time is very limited in the space still of my life. I think a book that I have gifted over the years, and it's definitely the opposite end of the spectrum, is The Shack. And it's just a book about just kind of the meaning in life and the things that are important and how you keep grounded. And so that's definitely a very deep philosophical book, but it was gifted to me. And over time, as I've seen people going through challenging times, I have shared that book with them just to give them a different perspective on all the different things at play.
Very cool. I love it. Question 2, who is a person, either dead or alive, who you'd love to meet?
Oh, that's kind of hard. I think I'm going to go with something really obvious. I would love to meet Florence Nightingale. Like, I would just love to pick her brain and like tell her thank you for helping kind of create this quality improvement things that we do for right now for nursing. So,
Yeah, I was actually going to say that as well. I think as a nurse, like, it would just be really interesting to just sit down at the table and get her perspective on where nursing was when she left it off. And then like even specifically where this program is and all the different things that we're doing. I think that would be a really dynamic conversation.
Yeah. Like, Flo, guess what we're doing?
Yeah. That's true. That's awesome. Question 3 is a bit different. Would you rather have super strength, super speed, or the ability to read people's minds?
I definitely don't want to read people's minds. I don't want the responsibility in that. So I think I would go with super strength.
Okay.
Yeah. I think I'd go with super speed or just the ability to clone myself.
Yeah.
I need, or add more hours into my day.
Right.
Any of those things would be okay.
Is that because you want to like have even more staff for virtual nursing? Is that why you want to clone yourself?
We need a little like, telephone booth where we can just kind of send people through, and on the other side, like another nurse comes out.
Yeah. Exactly.
High performing.
Love it. Question 4, what is something in healthcare that you believe that others might find insane?
The thing that came to mind for me first is just the complexity.
Right.
I think if you haven't experienced the healthcare situation where you required care, I think it seems very simplistic from the outside. Like, it's just doctors and nurses, and like, why does everything take so long? I think the complexity within healthcare is really eye-opening when people get kind of a glimpse behind the curtain and see everything it takes to make the ship run.
Okay.
Yeah, I think it's the volume of information that we have and the scientific advances that we have. So in 1950, it would take 50 years for medical knowledge to double, and now it's like 73 days. And just the amount of information that's out there, I think it makes me think that it's insane, and I think other people definitely would find it interesting.
Yeah, no, great point. So the last question that we had, and I apologize, Summer, I know you're a new mom, so maybe there's not a ton of time in the day for you for this, but what is the last film or TV show that you saw, and what did you think of it?
I can go first. She's 8, so I'm not like a new mom, but I have a big gap between my kiddos. So I still have this small child at home. And we actually did just watch a movie last week, so I'm going to get this answer right. We watched the new movie If. And I don't know if you guys have seen that. It's got Ryan Reynolds in it, and it's actually really good. It's funny. The story is good. So it was worth the time.
Awesome. Yes, yeah. John Krasinski, Ryan Reynolds. Yeah, that's fun.
I can't even think of any TV or movie that I have watched. It was probably some sort of reality TV embarrassment that I'm not going to say on a podcast. Real Housewives or something.
Oh, that's awesome. That's amazing. Well, the real meat and potatoes of today's conversation was a topic that you are super familiar with in virtual nursing. And so I do want to just thank you both for coming on the show today and honestly sharing some of your wisdom with our audience. Josh and I learn a ton every time that we hear you speak. So I'm super grateful to have you on today. That is unfortunately a wrap for this episode of The Digital Patient, hosted by SeamlessMD. You can follow us on Twitter at SeamlessMD. And if you like the podcast and you want to learn more, visit www.seamless.md. Again, Summer and Gina, thank you so much, both of you.
Thank you.
Thank you.